Welcome, Sam. I have Mr. Sam Rajaratnam here from the Cleveland Clinic to discuss the degenerative knee. Sam is a leading expert in the degenerative knee, having worked extensively in this area and doing a lot of knees. He's a workaholic, but he has seen a lot of these knees and is well placed to discuss them. So, Sam, tell us about some of your work at the Cleveland.
Well, Simon, it's a great honour to be here with you and to discuss all things regarding the worn-out knee. I'm privileged to be exclusively based at the Cleveland Clinic in London. It is a new American private hospital in the middle of Belgravia, 184 rooms.
It's a beautiful facility.
It's a lovely facility. And what is important is that it has got all of the capability. So it's got a floor of intensive care and high dependency unit, lots of physicians, cardiologists, cardiac surgeons, and every specialty you need. So in my world, which is only to do with knees, mostly the worn-out knee, but I do lots of injured knees too in the younger people. People often have other things wrong with them.
Yep.
And it is incredibly reassuring to know that under one house, you can cope with all of the medical complexity you might encounter. So that is quite nice. I love being there, and it's a good hospital.
Okay, it's a beautiful space, and yeah, it seems to be growing, definitely. And we'll touch on that a little bit later, but you came on to sort of comorbidities and how that might affect total knee replacements. But we're seeing a lot more TKRs, they're known, or total knees being performed at the moment. Like the National Joint Registry was stating that over 115,000 were done last year. And you do a lot of these, but your revision rate is incredibly low, which means that actually you get it right the first time. So how have you developed this technique?
Well, I mean, addressing the point of the numbers that are being done, not only in the UK, but worldwide, we're all living the 100-year life.
Yep.
Medicine's got better and people are living a long time. So it's not surprising that these procedures are becoming more common. Secondly, I think technology has moved on. Implant materials and things have moved on, where the vast majority of these interventions, if done correctly, should last 25 to 30 years, rather than the old-fashioned information that it lasted 10 years.
10 or 15 years.
That is absolutely not true,
Yeah.
because the manufacturing of things have got better. And we, as a profession, have got better at not only choosing who to do it on and then getting it right the first time,
Yep.
but also end-to-end care. So I think as a success of an operation improves, more are done. So that has really been my experience, and my life really has been dedicated to the improvement of the patient journey through knee pathology.
Yeah.
Have we got better at it? Well, the truth is it's a long answer. You have to firstly make the right diagnosis. You've got to work out what's going on.
How do you do that? What are the key steps in identifying? And degenerative knees are done because someone has a very osteoarthritic knee. How do you diagnose that initially?
Well, like anything in medicine, there are three things you have to do. You've got to speak to the patient. You've got to take a good history.
Yep.
The second is there are special investigations. And in my world, that is x-rays, it's special views, 4 different views, not 2, and MRI scans.
Okay.
And then you need to examine the patient.
Yep.
Now, the combination of these 3 things will then give you an idea of what's going on. And is a knee worn out in 1 part, 2 parts, or 3 parts?
And when you say 3 parts, you're talking about the medial aspect of the knee, the lateral aspect, or the outside, and the patellofemoral joint, or the kneecap?
Right. That's right. So the human knee is made up of the femur, the tibia, and the kneecap.
Yep.
And the ends of all of these bones are normally covered with beautiful surface cartilage.
Yes.
And then there are the shock absorber cartilages, which are the menisci. Now, as life goes on through injury or genetics or familial osteoarthritis, or indeed many other conditions that can eat away the surface, people lose their surface. Yep. And when the bone is exposed, that's what you call osteoarthritis. And that's either a primary thing, meaning it is just worn out through time and genetics, or secondary to infections and other things.
Yeah.
But the end result is that you wear things out.
Yeah. Is that happening because we're living longer, or is obesity contributing, or are we not doing enough exercise and that's knackering out the knee, so we're not keeping strong enough? Or do you have a view on that?
Well, I think it's all multifactorial, isn't it, Simon? Because ultimately, people are living longer and they want to be active for longer.
Yeah.
Certainly, obesity will have a role to play in that. Family genetics. Certain families have, worn out knee genes or worn out, osteoarthritic genes.
You often see that, don't you?
And you often see that. Yeah, exactly that. And then, of course, what has happened to you in your life? Have you had a knee injury? Have you lost your meniscal shock absorber? Have you had a ligament injury?
Yeah.
That sort of thing. Now, the other interesting thing is that 30 years ago, the inflamed knee, such as the rheumatoid knee or the psoriatic arthropathy knee, was very common. And 30 years ago, my predecessors, 40% of their workload might have been the rheumatoid knee. But of course, these days it's probably less than 1% of my workload because the drugs have got better controlling
the
these.
biologics.
The biologics have really transformed the inflammatory arthritides. But the end result is people wear their knees out.
Yeah.
And so now there are then nuances. About 60 and 100 will wear the inside of their knee out and their knee will become bow-legged. That's a very painful pattern of arthritis and they present early. But 20 and 100 will present with the knock-knee variety.
The valgus.
The valgus knee. Yeah. And that can basically start as giving way. And then later on, a crooked leg and pain. But pain is a late feature. Now, it is very important that people understand that this needs an early diagnosis.
Yeah.
And if your knee starts giving way or feels unstable, please get the diagnostics done early. It's often missed by professionals because it's a wearing of the flexor surface of the knee, not the extensor surface. The final thing that is really common, Simon, is pain at the back of the leg. And that is called a Baker's cyst. Now, a Baker's cyst is not serious, but it's just an increasing amount of fluid in the knee due to something that is not quite right. And so you've got to go and say, well, what is it that's not right? And very often there's wear and tear in the knee that's
most
causing
of the time there's some internal derangement or pathology that's causing that fluid to leak out, isn't it?
Exactly that. And in a healthy young person's knee, the synovial membrane will create 1 mil of lubrication, which just wets the surface. Whereas in a knee that is osteoarthritic or has got a torn meniscus or a ligament insufficiency for over a long period of time, the knee may then produce 20 or 30 or 40 mils of engine oil, which then bursts outside the knee. And very often people soldier on with their worn surface. But when the Baker's cyst bursts or leaks into the calf and gives them pain down the leg, that is exquisitely painful.
It's painful.
And then they come.
So then they're worried about a DVT and then...
and the whole cycle of events that go with that. So fundamentally, so you see people. Now, how do you get the diagnostics right? Well,
so you mentioned 4 views on an X-ray.
Yeah.
Because a lot of the time we don't see all of those views.
No, that's right. So a knee surgeon will always ask for 4 views. The first is antero-posterior standing view. So you stand up and you get an X-ray and there's a front-on view.
Yep. Which is weight-bearing.
Which is weight-bearing.
Yep.
Really non-weight-bearing knee views are pretty useless.
Yeah.
The second is a lateral, that is looking at it from the side. The third is a skyline as a shoot-through looking at the kneecap joint. Yep. And then the fourth view, which is incredibly helpful, is called a Rosenberg or Schuss view, rather like a skier skiing downhill with the knee 30 degrees bent.
Yep.
And that unmasks the lateral joint line disease and also subtleties on the medial disease. So you can pick things up.
Yep.
And where on the standing front-on or back-to-front view, one might look like they've got a joint space. On the Rosenberg view, you can see it's bone on bone.
Yes, okay.
And that, because if you don't have that, you then can get confused with the MRI reports that you see in a degenerate knee, because it'll often talk about a degenerate meniscal tear.
Yep.
And then you think it's got a meniscal tear pathology when in fact it's a worn-out knee.
Yeah, okay. And so you offer this one-stop shop sort of service to make life easy for people, to make it quick, to make it efficient, so you get it all right the first time. Now, how much weight, are the X-rays the most important, or is the MR, or is it just a combination of your clinical knowledge, the functional and clinical assessment, and the radiology?
Absolutely. So radiology is there to help you make the diagnosis.
Yeah.
But what is really important is the patient. So, whether if a knee looks terrible, but in fact the patient is wonderful, you're not going to do anything. So
Yeah.
this is actually about people.
Yes.
Understanding what is wrong with them, giving them an accurate diagnosis, and then trying to guide them as to what their options are.
Yeah.
Now, I get the 4 X-rays and very often an MRI scan. You might say, well, why is that? Well, partly this one-stop service is because I work very closely with world-class radiologists, and we pre-organize the imaging because I've got a national and an international practice. People are often coming a long way to see me.
Yeah.
And therefore, you don't want them to come 3 times.
Yeah.
You kind of want to
makes it
tell
much
them what's
easier.
going. Much easier for them. And it's more time efficient.
Patients are often asking, "Oh, can we get the imaging done before?"
That's exactly right. So
perfect
so
sense.
very often, I would ask them, or my practice team will organize their imaging. They'll come an hour early. They'll get it all done. And then by the time I see them, I've already got the reports and I've got exactly a map of their whole knee. The second reason to get MRIs in particular, because that's not always universally done for the degenerate knee, is because I can then explain why it hurts in one place or the other. And then the final bit that I find incredibly useful is when I'm trying to work out whether the surgery should be a partial knee or a full knee, it is nice to map the whole cartilage of the knee and know where the deficiencies are. And if a disease is only affecting 1/3 of the knee, then a partial knee might be a very good option for that. But if the disease is affecting the other 2/3 of the knee, more than 1/3, then it seems silly to address that for the patient to carry on being in pain after the whole journey and then need either a revision or additional surgery. So the best chance of getting it right is to get the diagnostics and the therapeutics right the first time. And really, I guess, I'm in a privileged position. I love treating my patients, and it's a great honor and a privilege to be in the position to give them good advice. And you want to give them the right advice.
Yeah, completely. And I think that is across healthcare and medicine. You need the right diagnosis up front, and you need that information across the board, whether it be a knee, a spine, or a shoulder. You need that imaging in conjunction with that clinical assessment.
Exactly that.
Now, it strikes me as odd that we call a total knee replacement, and it's not really a knee replacement. You're almost just resurfacing some of the knee. So can you explain a little bit about that procedure?
Exactly. So I think the word knee replacement or total knee replacement has really stuck from the 1970s when these things were developing. And at that time, the designs were more hinge-like designs. They were not knee-shaped. And the materials, of course, weren't as good. And implant design over the last 60 years has moved tremendously, or 55 years. These days, what is traditionally called a partial or a total knee replacement is really a resurfacing of the joint. It's like going to the dentist and having a crown fitted on your tooth. And the dentist is trying to work out whether a big filling would do or whether he would have to do a crown. And really, I would see, so it'll be much kinder and much more accurate to call it a total resurfacing of the knee.
Now, less scary for clients.
Really scary. You think, oh my God.
They sort of think, oh, right, he's going to chop off here, he's going to chop off here. And
exactly.
I've got this new implant.
Exactly. Whereas these days, you can approach these in a minimally invasive way. Smaller incisions, moving tissues to one side. And you're really sculpturing the surface and you're covering it with a knee-shaped surface. And really, you're removing between 1 and 9 millimeters of tissue that then can take a surface that hopefully mirrors what you had in your native knee.
So patient selection is often so key to surgery and getting a very, very good outcome. And you get incredible outcomes with your surgery because we've seen lots of your patients and they do phenomenally well because you manage them incredibly well, but the surgery is just slick. Now, how do you select the right patient, either for a hemiarthroplasty or that uni-compartmental knee or the total knee? And are there some that you don't proceed at that point in time?
Yes. I mean, actually, when I look at my overall clinic workload, my ratio of when I see somebody and then I operate is probably only 1 in 7.
Yeah.
So the key thing is you've got to take joy in understanding the patient, understanding how their knee pathology fits in with their life.
Yeah.
What are their expectations? Are they, what's their hand of cards medically?
Yes. Yeah.
What do they want to do with it? Is it better to wait, or is it harmful to wait?
Yeah.
So, for instance, if somebody is just about to lose their fitness and they've got comorbidities, getting on with an operation may be absolutely the right thing to do.
Yeah.
On the other hand, if somebody comes to you with very early degeneration, then they might not be mentally or physically ready for it. So patient selection, I think, is probably the most important aspect of this, and understanding patients and empowering them to make the decision. We've moved away from doctors telling patients what to do. Patients will know what they want, but my job is to kind of empower them. So that is a key thing. I see my job as an advisor to patients, rather like in the degenerative knee, when you decide on operating on them. A good analogy is really like a master winemaker. He decides when he wants to harvest the grape. You don't want to pick it raw, and you don't want to pick it rotten, because you don't make fine wine by doing that. So there is often an optimum time.
It's a perfect sort of window.
There is a window. And so really the expertise, I guess, of me seeing 6,000 or 7,000 people a year for 20 years or so in clinic means that you get good at judging where that window is.
Some decent volume.
Well,
you gather a lot of clinical experience from that.
Yes, exactly. And also, I guess, because I've got a large element of what I do is a word of mouth practice, it's easier because people come to you having got your name from other doctors, other friends, and so that's lovely at this stage of my career, because in fact you feel you know people the first time you meet them, because they've met 2 or 3 people who've treated, so
definitely
they know you.
How would you select someone for a unicompartmental knee versus a total knee replacement? Is there you want someone that just has that 1/3 degenerative knee rather than affecting the rest of the 2/3?
Yeah. So really, what I'm trying to work out is, if I do an operation on somebody, are they going to go away happy for the next 30 years or so? I don't really want to be doing something.
And you think they're lasting 25 to 30 years
Most of these are lasting a long time. The materials have got better, and our techniques have got quite robust. So regardless of one or the other, doing something that then needs to be redone in 3 or 5 years because they've got pain and already degeneration in the other doesn't make any sense. So for a uni, it'll be unicompartmental disease, meaning that it is disease and degeneration in only one compartment. Now, the second caveat is we briefly talked about the inflammatory arthritides, where in certain patients, the joint is being dissolved by biochemical and immunological processes. And in that situation, replacing 1/3 of it is silly, because
doesn't make sense.
It's going to the inflammatory process is going to eat away at the other bits. And then the final bit is, when you technically do it, you have to make sure that the plumb line generally loads that compartment that's replaced, because if you get it subtly wrong, the other bit wears out quite. You overload the other bit. So there are some technical things you need to be able to pull off after you make the decision. So those are my criteria, and I'm very careful. And probably about 15% or 20% of people I do, each year I might do 550 to 600 joint replacements and 300 soft tissue operations, so about 900 ops a year. But probably this coming year in 2025, probably 60 of them might be partials. But really everyone gets the bespoke advice that they need, and what is important is not being didactic. You want to give people a plan that works for them.
Because people want to know that this is going to last them. People are living longer, and often patients will. I find myself now seeing a lot of degenerative knees, and having seen a lot of knees over the years, I will generally now be encouraging people to be more proactive about going for a knee replacement earlier than what I would have 10 years ago, 15 years ago, because I think of all the the things that you've mentioned. Patient selection is better, techniques are better. You've pushed the envelope in terms of recovery, and the prosthetic material has probably had quite an impact on that as well.
Quite a lot of that. And then, of course, lots of advances in the technology, robotics, as well as implant designs. And we'll talk about that in a second. But what am I looking for? So I'm looking for a number of things. Do we have an accurate diagnosis? Well, we talked about that. What is the impact on the person's quality of life?
Yes.
Is their life becoming smaller because of this? Are they suffering? Now, the nature of the osteoarthritic knee is it doesn't hurt the same amount every day. Every day and every week and every month is different. And some days are miserable and some days are good. And really the patient will come to their own understanding that they're not going to want to live with that. There are adjunctive things one wants to do. You and I work very closely together, and often in the prehabilitative setting, I'll say, Simon, can you try and get rid of the contractures? Can you get the knee straight and can you get it bent? Because if I operate on a supple knee, that leads to better results.
Yes.
Actually, more important than having good muscles is having a hinge that actually works like a hinge.
Exactly.
Basically.
You need good range of motion.
You need good range of motion. Now then, on the inside of the knee, these modern replacements are surface replacements. But in order for them to work, you need good ligaments. So if you're stretching your ligaments and you're becoming incompetent, you get to a point where the surface replacements don't work. They're unstable.
Yeah.
And then you need to put in more constrained implants.
And
Not
is that
quite.
particularly for that cohort of patients who have more of the knock knees or the valgus?
So
you see that?
Exactly. So the problem with the valgus knee is it hurts less early on, so they turn up late.
Yeah.
And then the medial collateral ligament can stretch.
Yeah.
And if the MCL is really incompetent, then basically you may not want to trust a surface replacement.
Yeah.
And so in that setting, when the leg is wobbly, but there might not be that much pain, actually it's better for the patient to go in earlier because you get a less invasive operation, you see. But that is really the judgment call, and we've got all the kit.
Yeah.
And often we've got plan A and plan B and plan C, so we can do that. But, that is why the decision to operate and the timing is based around the patient's suffering, but also knowing what is coming down the line.
Yeah, patient suffering and their function. I think it's got to be how much, part of that needs to be how much it's impacting on their life.
Exactly that. But, the three pillars are pain, deformity, and loss of function.
Yeah.
And you could have one, both, or all three.
Yes.
And you also need to be able to tell the patients that, that explain why the timing is right for them.
Yeah. And, there's this big wellness push at the moment and longevity and optimizing I think it's optimizing people's health span so that they can, the last 10 or 15 years can be far more productive and you can be healthy and keep function. And if, your knees go, your hip goes, it's pretty hard to actually keep strong, to keep stable and actually be able to run around with your grandchildren. So I think
absolutely, and also you want to prevent falls, and you want all of these things. I mean, in my 8,000 or so joint replacements that I've done, I think the oldest I've done was 99, and the youngest probably in their late 20s because of whatever pathology that they had. The UK average is 67. But it's a broad church.
Yeah.
Age actually doesn't matter as much as fitness.
Yes.
Because you might get a 60-year-old who's terribly unwell with multiple comorbidities and a 95-year-old who actually is very well. And
very
so...
fit, and we see those sort of walk through the clinic.
Yeah. So doing it whilst you're healthy, getting it right the first time, organising their care so that they get better quickly.
Yeah.
And then them having a healthy life. And this is one thing that can be taken out of the equation.
Yes.
If it's done well, is always going to benefit quality of life.
Yeah.
And that's what I'd want for myself.
Okay. So we talked about, the optimal time for having a knee replacement or a knee resurfacing. And is there a role for, kicking the can down the road a little bit with some steroid injections, with maybe some PRP or we've got arthrosamid that's come onto the market. The lubricant injections have been around a while. Are they delaying the inevitable? Or are they offering sometimes a good 2, 4, 5 years if there's not a lot of deformity in the knee?
It's very difficult to know, really, because the truth is none of those things are actually curing the problem.
No.
So very often they're an anti-inflammatory agent, and some of these new things are cropping up every week. I'm a great advocate of not being a snake oil salesman.
Mhm.
Now, I work very closely with sports medicine physicians, and for some patients, an injection will buy them a little bit of time.
Yeah.
Often because they haven't suffered quite enough, or there is an inflammatory thing that is causing the acute pain. They might have life events, and they might not be mentally ready or physically ready. So I think there is a limited role for it. The corollary of that is repeated injections with worsening deformity and stiffness empties your wallet and doesn't actually help you in the long term.
And perhaps I don't know if you see it within surgery, do you see the impact on the joint surfaces?
Yeah, you do.
From repeated steroid injections?
You do. So steroid can weaken the bone.
Yeah.
And sometimes it can cause something called avascular necrosis, where only last week I had a patient who had a meniscal tear.
Yeah.
And they'd been injected with steroid. And now they've got avascular necrosis, right? So the cure for the meniscal tear was a tiny 12-minute keyhole operation.
Yeah.
Now they've got something new.
Yeah.
So every action in medicine has an equal and opposite reaction somewhere along the line. There are some of these newer products which even the companies can't tell you whether they work. And by the time the randomized controlled trials prove that they do work or don't work, actually, they might not be around. So one has to always be very careful in caveating the injection therapies. There is a role for them, but it's a limited role. And it should be done not as a rationing tool for getting good advice, but as a broad picture of the kind of things we might do before we go for surgery.
Yeah, I think patients like having those as options, but I think explaining to them quite carefully that this might buy you a bigger window until you need to go down that pathway, because often patients almost need to be drip fed with that and take that on board. Maybe you see a lot more of these, but a lot of the ones that need some sort of surgery often need to hear that, let it ruminate, sit with it, and then realize, no, actually, there's something more I can do here.
Yeah.
Let's go down that pathway.
So that's exactly right, which is why I say it's as much of a mental journey and an education journey and an understanding of their own body and, and there is a role for it. In my experience, really, the injectables tend to work for a few months rather than a few years.
Yeah.
And I would say the vast majority will probably work for about 3 months.
Yeah.
They might occasionally work for 6, but I don't see them going away for years.
Yeah. The arthrosamid users might claim that's a little bit different, but I think it's early to the market, so let's see where that goes.
Yeah, I mean, again, I don't really want to say something for or against it, because I see a lot of people with injectables that haven't worked.
Yeah.
So I guess I see a slightly different
you
cohort
have a slightly
of people.
cohort.
Yeah.
So you have really sort of pioneered this surgery in terms of making it significantly less painful for people. And the ones that we see come out and they're doing incredibly well very quickly. So what is it that you've done to really try and optimize the surgery, and how do you try to sort of preserve that soft tissue as much as possible?
So the real truth is the magic is that there is no magic. You just need to do 100 things a little bit better.
Mm-hmm. So a Dave Brailsford type approach.
Very much a Dave Brailsford approach. So cumulative marginal gains, and of course having an amazing team.
Yeah.
So once you get the diagnostics right, and you're operating on the patient at the right time on their journey of life, the next bit moves on to, okay, well, how do we get this right?
Yeah.
So on the surgical side, we now do less invasive surgery.
Okay.
How do we do that? Well, in my theatre is a headhunted team who between them have done 80 to 100,000 joint replacements. So we've been
just-
together a
just
long
a couple.
time. Just a couple. So, but actually, these are people who've come on the journey of life. They are very, very good at what they do.
Yeah.
I get all the accolade because I'm the one at the front of, front of patients. But actually, they are the unsung heroes.
Yeah.
And if your nurse has done 10 or 15,000, and you've got 3 of them, it means that everything is organized, and you can actually
I've seen it before.
You can. The surgery then doesn't take very long. Yeah. So it means that on the surgical side, you can do it through a smaller incision. Mm-hmm. Your assistants have done tens of thousands, so you can see all the tissue that you want to see. The nurses are giving you all the equipment you need very quickly. So a normal knee takes about half an hour in our practice, which means that you have less anesthetic, less surgery, the wound is not open for longer, and you have less complications. So that is a big surgical advance. We'll talk about robotics in a while. And of course, implants have got better and better. They wear better, but they're also more knee-shaped. And guess what? If they're more knee-shaped, they perform like the native knee. Yeah?
Yeah.
So on the surgical side, tremendous advances.
Yep.
On the anesthetic side, I've been privileged to work with one remarkable, amazing anaesthetist and intensivist called Dr. Barry Phillips.
Okay.
And Barry and I have done the vast majority of our surgery together. Mm-hmm. And we have innovated together local anesthetic specific cocktails, drip feeding local anesthetic into nerves, etc.
IV
well, it's called infusions, nerve blocks, but you can top them up as well.
Yep.
And then pericapsular infiltration, that is local anesthetics and things that reduce bleeding, to then reduce the surgical insult. So, and we often give people lots of different types of anesthetics. So they might be asleep for a short period of time. They might have a spinal, but when they're asleep, so that you have the advantage of that. So you have 4 different types of anesthetic, so you don't need much of anything. Yeah. And with the precision surgery, they then come through without too much trouble. Yeah. We've also then tweaked our technique so that people can be walking within 3 or 4 hours of surgery.
Yeah, which is quite incredible to think that they're only under for 30 minutes. You're putting a new surface on the knee and suddenly they're up.
And they're up and walking. And that reduces blood clots and chest infections and all the other things that you get with that. So you get less surgical complications, but less perioperative complications because they're mobile. Now, the corollary is, as we have made a horribly painful operation much less painful and quite comfortable, the patient then can get a bit greedy on their rehab. So they can then overdo it. So you then need to very carefully manage the journey with partner physiotherapists and end-to-end rehabilitation. Yes. And so I'm actually privileged because, of course, at this pointy end of my career, I'm only working with very good physios that understand this process, like you and your team, and therefore we can manage the soft issues. Yeah. And meaning that you're trying to prevent swelling, and you're trying to let the soft tissues heal. And you're offloading the joint, and you're trying to emphasize the return of range of motion over muscle building. Because, of course, after the healing process ends, you've got 30 years.
You've got plenty of time to do
that. But if you try and do that early, you're bullying the tissue, and therefore it remains.
I've learned through experience, a little bit long in the tooth now, but and I've probably caused some capsulitis over the years with people where we've tried to push range, but actually, and perhaps put a little bit too much load in them. But now we're so strict. Okay, you can only do X number of steps for the first 2 weeks. We don't want you being too greedy, doing too much, overstepping the mark, and actually just keeping the knee happy is one of the best things you can possibly do, which is
exactly that. And so you're basically trying to give them time to heal. I must say, I like capsular stretching. So pushing range is a good thing. Yeah. But I guess repetitive cycles of muscular loading is not so helpful in the early stage. So it's a balance. And the other thing, of course, Simon, which you'll have a comment on, is using your hands as a therapist to massage and get that movement is so key, isn't it? Because they're in your world, particularly in the UK, there's been a move away from.
There's marked inhibition of the quads. There's spasm. There's bruising. There's bleeding. it's almost a soft tissue surgery that's gone on. There's perhaps some subtle alignment changes, and that takes time for that tissue to settle down. And whilst manual therapy and tissue work is perhaps a little bit of a dirty word in the physio community in the UK, you can make an enormous difference.
Yeah.
To actually just having someone regularly come in,
Yes.
check you, ideally home visits so that they're not getting up and about too frequently, but actually doing some good massage, freeing up your quads, freeing up your hamstrings, gently unlocking that popliteus, releasing off the calf. All of that makes a big, big difference to how the knee can just comfortably start moving and bending.
Very much so. The other thing, apart from the technical skills that you guys give us, is two other things. Number one is if somebody has done a lot of joint replacement rehabilitation, they can answer questions.
Yeah.
And patients have lots of questions
Yeah.
because they're going through it for the first time. And for me, what is incredibly valuable on this team-based approach is I can control my in-hospital team. But when I work with consistent teams outside hospital, they watch my patients for me.
Yeah.
And you and I and the other partner physios I have an ongoing narrative so that they're talking to my nurse consultants and
Yes.
organizing their pain relief. And I know who's doing too much and too little. And so you can track patients.
Yep.
And I really strongly believe in what's called end-to-end care.
Mm-hmm.
So I just hope the patients who come and see me buy into the idea that they're going through this for the first time. And if we can work as a team,
Yeah.
not only surgically, but actually until they're better, they're going to feel looked after and not
Completely.
abandoned.
Completely.
And so that's a big part.
I think how much of a role is that perhaps prehab, or is it just the education that they're getting, as well as maybe the capsular stretching, trying to remove not remove adhesions, but free up the knee a little bit, because and there's lots of evidence to support prehab in various sort of operations, but actually patients seem to do significantly better if they've been seen beforehand, if they've had the operation carefully explained, mapped out timeframes, their expectations are better. Is that something that you have come across?
I'm a huge fan of that. But actually, let's break it down into what is important. Number one is the patient needs time to understand what is going on,
Yeah.
and to basically to learn more about their process. And actually, the ability to tell them what they're going to be like on day 4 when they get home, at 1 week, at 2 weeks, at 6 weeks, is incredibly helpful for the patient. And then you just have to fulfill those landmarks if you can.
Yep.
So patient education is a huge part. Secondly, you know that there is a role in getting rid of contractures, because patients do all sorts of naughty things when their knees wear out. They sleep with pillows behind their knee or whatever. And
I don't mind some people doing that, because if it means that they sleep,
Understood.
their recovery might be better. But
Understood.
in certain circumstances.
But if it leads to a fixed flexion deformity,
Correct.
then that is bad. So the truth is, I'm not generically a fan, but only because if the knee goes straight before I operate on them, it's so easy to get it straight afterwards. So contractures are a bad thing, and you'll get rid of that as much as you can before they come in. The final bit really on the prehab is really about building trust.
Yeah.
And if a patient is not fearful, because they know
Yeah.
that when they get home and they leave the ultra controlled environment of a hospital setting with my whole team and other specialists and everything else looking after them together, and they go
There's
home.
a lot of other things that can happen and crop up.
And if they feel that actually my eyes and ears are on them via these wonderful therapists at home, it makes a huge difference.
Yeah.
Can I also say that ice therapy or cryotherapy is incredibly helpful? It reduces pain and swelling, and actually it's huge. But essentially, people only go home after 2 or 3 days having gone up and down stairs. So you're mobile, your wounds are healing, there shouldn't be any leakiness or anything like that in the wounds, because we meticulously close the wounds. And then really you are trying to manage them with a variety of different pain relieving methods at home.
Because it is still a little bit uncomfortable and a little bit, can be a little bit painful for people. But it's actually the fear that you alluded to, the anxiety that people have with this, that can cause, quite a lot of anxiety, quite a lot of issues in that sort of initial sort of rehab process.
Yeah, I mean, actually, that's one thing I'm really proud of with our end-to-end care for patients
Yeah.
and our expertise on how we've really improved the pain around this.
Yeah.
Really, our pain scores are somewhere between 0 and 4 out of 10, not between 7 and 10 out of 10.
Yeah.
Now, of course, the high-end clientele that I see at the Cleveland Clinic London, 4 out of 10 pain might seem
A lot.
a lot for them. But we're consistently delivering much less pain post-surgery, and really, I would summarize by saying we've made a totally horrible operation perfectly tolerable.
Yeah.
I don't know whether we've made it nice, and some people, they'll sail through it, and other people will have a little bit more, recovering. But actually, the vast majority, and everyone is slightly different. So
completely. Everyone responds a little bit differently to those situations. But I think you touched on it before. The sort of game ready or physio lab machines, which are the ice and gentle compression, are game changers for knee operations.
Well, every little bit helps, and so these are all the part of the marginal gains. And, it's not surprising that if you go for all of the marginal gains, you're likely to have a much better result.
Completely.
I mean, it's all about attention to detail.
And it's almost that enforced rest that they need to do when they're doing it 3 to 5 times a day, and they're doing their little flexion-based exercises and little extension exercises, and then, it's ice time. Exactly. So they're resting and they can't overdo things.
Exactly. Can I also talk about the fact that people's home environment needs to be optimized?
Yep.
One mustn't be too brave. You must, allow people to help you. If you live on your own, actually having a friend to come and stay for a week,
completely,
it's unbelievably helpful. They get you food and water. You've got a bit of company, and you're going through an awkward journey.
Yeah.
And you're going to repay people in life. So very often, these are the bits that we as a team concentrate on getting in place, because if you don't get this in place, you're going to be caught short.
You can struggle around on crutches, and at home you can't carry food. How do you prepare? If you're having to stand on your feet all day, prepping a little bit of food, and you've got no help, it's a challenge. You need some assistance for this sort of operation.
And my message to patients listening to this is really that, you might be going through this the first time, but we see this 20 times a week, and so we can predict often the troubles that one would have. And so, it's a journey.
Yeah. We've touched on the bespoke nature of knee replacements. How do you select, a customized knee or a robotic knee? Is there a process that you might go through, and are there certain cohorts of degenerative knees that are better for one or the other?
Yeah. So, the word customized is often misconstrued in knee replacement surgery. There are companies that basically get a CT scan of a knee and then will send you a knee in the box, which sounds like a customized knee, but that might come with significant disadvantages of if it doesn't fit or you don't have the modularity in it to give you a stable knee, you might then leave the patient unstable. So actually, what is sometimes sold to you may not be actually what it is sold.
Yeah.
Can I go back to the basic principles of knee resurfacing surgery?
Yeah, sure.
What you're trying to do is you're trying to basically custom fit the patient with a surface that mimics the surface they had when they were young, which of course is a guess. If you see somebody who's 60 years old, I really have no idea what their knee looked like when they were 20 because it wasn't mapped when they were 20. But the ideal is you want to give them something that feels natural. So that's the first thing. The second
how do you do that? How do you sort of... Is that just through experience and understanding?
Well, some people are made slightly bow-legged. Yeah. Some people are made knock-kneed. They can often tell you which shape of leg they've got. So a lot of professional footballers or sportsmen are made slightly bow-legged.
Yeah.
And when you finish with them, if you suddenly make them knock-kneed, actually they're going to be really unhappy because their knee's not made for that. So the first pillar is really getting a surface that mimics their natural surface, which comes with experience. The second is the alignment philosophy, aligning the hip, knee, and ankle appropriately. Now, what is appropriate? Well, no one can agree on that. There are, as we stand today in 2025, there are 6 alignment philosophies. Mechanical alignment, kinematic alignment, reverse kinematic alignment, restricted kinematic alignment, functional alignment, and others. Personalized alignment.
Yeah.
And every few months, somebody will come up with a new alignment technique. So the medical fraternity around the world can't agree.
Don't actually know.
They don't actually know.
Yeah.
But my philosophy has been really something called functional alignment, where you're trying to guess what they look like when they were 20, and you're trying to custom fit them. Now, the final bit, which is really important, is you need to leave them with a stable joint. Mm-hmm. Now, this requires lots of different shapes and sizes of the bearing surface.
Yeah.
Now, if you take a photograph...
When you say the bearing surfaces, are you talking about the weight-bearing surfaces?
Well, no, it's not only the bits that crown the end of the femur and the tibia, but the polythene bearing that goes on the inside, which acts as the artificial cartilage.
Yep.
Now, in what is sometimes sold as the custom-made knee, you only get 1 or 2 bearing surfaces. Yep. So you can then leave the patient unstable. And I've replaced or had to revise a number of these things that were left unstable over time. So in my philosophy, I use a system that gives me 12,000 different custom fitting options. Mm-hmm. It's like a master tailor having lots of cloth to basically take in and out. And you can then leave the patient with a surface that covers the bone adequately, with an alignment and philosophy that you believe in, and stable. And that is key. Because one of the previous historical reasons for unhappiness was something called mid-flexion instability, meaning that the joint was unstable, even though it looked all right on X-ray.
Yeah.
And therefore, a lot of patients were unhappy with their knee replacements.
Is that where you need your Rosenberg view there? Would that pick it up?
No, not in the post-operative setting, actually. Yeah. So once somebody's had a knee replacement and the implants have been put in place, actually, if they're unhappy with it, a lot of the time, you can't really, I mean, there aren't lovely solutions.
Yeah.
X-rays might look lovely, but in fact, they might have mid-flexion instability, or it might not feel natural to them. So getting it right the first time is a real art, actually.
Yeah. Okay. And so how would you then look at using any robotic surgery or robotic assisted surgery, I think, really?
Yeah. So I was lucky because I sort of, in the UK, had the first Zimmer Biomet ROSA robot. So I had the first one in the commercial sector about 5 years ago. And the human race is at the beginning of the robotic journey, not the end of the robotic journey.
Yeah.
It's really like having satellite navigation. You put some sensors in and you map the native knee, and it gives you some data telling you where the hip is, the ankle is, and the knee is. And it can give you some soft tissue balancing data too.
Okay.
And so I've helped develop ROSA robotics here in the UK. But of course, things are changing. And there are AI algorithms and things changing what we know.
It's like Google Maps is changing.
It's always changing. And in time, this will probably make the terrible surgeon better.
Yeah.
But will it make a good surgeon brilliant? Difficult to say. Mm-hmm. So today, when you look at world literature, robotic and non-robotic surgery seem to have the same outcomes. You know, but in time, will it change? We don't know. It is important when you choose who to do robotic surgery on that you're not harming the patient, because it does take a little bit longer.
Yeah.
You know,
so how much longer?
In my case, non-robotic surgery for a knee replacement takes about 30 minutes, and robotic surgery might add another 10 minutes to it.
And that's a little bit of time that you've got a tourniquet on, that the soft tissues are compromised, that you've got the wound open.
That's right. So it's not a free hit, if you see what I mean.
Yeah.
And so I would counsel people from not falling for fads or falling for the marketing. In some people who are very healthy, who've got very little other problems going on, it might be a slight advantage.
Yep.
But in others, if you're a diabetic or you have cardiac issues or other surgery, that extra time may make a material difference. And therefore, I am very upfront and honest with patients. and we talk about the pros and cons of this, and we come up with a bespoke plan, because my duty of care is to give the best advice I can to the patients, and only do something if I genuinely feel it's going to be a great improvement for them.
Okay. So your approach is definitely one of a functional, trying to optimize that functional alignment, which makes sense. Just thinking about it, you know, from a with my physio hat on. And more of the time you'd steer towards a customized approach rather than the robotic assisted, because you feel as though that gives you the best results and the best outcome, because technically...
Actually, I'm a fan of both. I mean, you know, the truth is that we don't oversell one or the other. You have to look at the patients. You've got to look at their comorbidities. You know, using the robot is an adjunct to doing a good job, and actually looking after the patient really carefully. I would really encourage the patient not get hung up on some of these technicalities, and I don't want to undersell it or oversell it. Everyone needs a bespoke hand of cards read, and the pros and cons. They need to look at the National Joint Registry data and outcomes. In the UK here, we've got an amazing registry with 4 million data sets. You know, you should look at it, be able to look at your surgeon and say, how many have you done? And what are your failures? You know, and I'm very transparent on not only my revision rates and where I sit within the UK fraternity, but actually on outcome data. What are your pain scores 6 months post-op? What are your, you know, what are your knee scores? What are your quality of life indices? And we can, and really, you know, finding that out later is too late. You kind of need to find that out before you undergo surgery, so you can be educated. I mean, you wouldn't invest all your money with a fund manager who you met in the pub and you had no idea of his track record over the last 10 years.
You'd hope not anyway.
Well, you hope not anyway. He might be very convincing. But so we live in an era where data and transparency and outcomes need to be paramount to people's decision making. And it's amazing to me that actually people might go, oh, well, I just went locally because, in fact, the parking's a bit better. You're having one of the most important interventions that are going to shape the next 30 years of your life. You know, go and seek excellent care. It's worth it.
It's still amazing how some people, I think this is changing, but some people still think very little about their health and feel as though, okay, their GP or their doctor, okay, they're making the right decisions. I'll just completely trust them. I think people need to have, you know, a degree, you know, you need to trust completely who you're working with. But people don't do enough research all the time. There's a lot of people who over-research things, but I think what I'm trying to say is that, you know, it still surprises me how little people invest in knowledge, learning about what they're about to go through.
Well, it's difficult to comment, isn't it? I mean, you know, we live in a wonderful democracy, and we get the government that the electorate vote for. And like that, you know, you get the healthcare that you deserve by doing the research that you want. And if you invest in your health, if you value it, then do your research and don't compromise on all of the 1%. Because that is going to give you a better life.
You've got to optimize a lot of different aspects. Now, jumping forwards a little bit in terms of recovery, you know, people often ask, well, what can I do with my total knee? Can I run? Can I play tennis? How quickly can I get back on the golf course? What's your view on perhaps people running first? Are the surfaces tolerating this a bit better, or do you prefer people not to because you want them to go for 30 years?
Well, I think it's a complex answer, isn't it? I mean, firstly, if I can talk about the standard recovery that people go through, well, they're able to walk within 4 hours. They're able to go up and down stairs on day 2. And by day 14, when they come and see me, the vast majority are able to drive and they're able to function. Now, sleeping at night can be dodgy for about 6 weeks because there is a healing process. And if you can be even if you're doing brilliantly, if you can limit your step count in week 3 and 4, it lets the soft tissues heal.
Correct,
And you then get your life back at about 6 weeks. But that is not the end of the recovery. it continues to improve month on month for a year.
Yeah.
So the vast majority of my patients are driving between 2 and 4 weeks, and between 6 and 8 weeks they're going back to sort of light things like golf and tennis. But there is a variation on that. There'll be some who are naughty and go a bit earlier, and some who take a bit longer. Then really there are things that I really encourage: swimming, cycling, walking, golf, tennis, and skiing are all things you can do on a joint placement because they're glidey movements and you're not bashing the surface. But fundamentally, if you run on it, the shock loading that you put through an implant has got to wear the surface. Now, if you watch Formula One every weekend, and I'm a Formula One fan, Lewis Hamilton's car tires.
Ferrari now with Lewis Hamilton?
Well, I'm hoping he does well. I'm proud of what he's achieved here in Britain. But Lewis Hamilton's car tires don't last as long as mine because they're driving. It's about a wear thing.
Yeah.
And so, if you want to preserve your knee for a long time, then you've got to treat it with respect.
Yeah.
That will be the same thing your dentist will tell you if he gives you the world's best crown. If you chew on boiled sweets or hard things.
So you're being very diplomatic here in saying, no, I'd prefer my patients perhaps didn't run.
Well, I think where I draw the line is I say if something brings you tremendous joy, like playing tennis, you're running a bit, you're standing a bit, and you're hitting the ball. Running, I think, within that sphere is fine.
Yeah.
If you're going and running a marathon on an implant, I think it's going to wear out sooner.
Yeah.
So it's not a diplomatic thing. You decide whether you want to rob Peter to pay Paul.
Yeah.
And Paul needs paying.
Yeah. Yeah, completely. So that sort of rehab process, that 2 to 6 week period is really quite a calculated, careful process of slowly building people back into function, really.
Yeah.
We try to get the knee moving. We try to keep the knee happy. We really don't want to allow that tissue and that knee to swell too much. And then we gently encourage them back into normal activities rather than pushing any high strength exercises. And that comes way down the line.
Exactly. So that's so important because remember that basically people are also trying to heal. Their tissues are trying to heal.
Yeah.
And if you bully the tissues, they don't sleep at night.
Yeah.
And they get a capsulitis. And once their knee is inflamed, it takes months for it to settle, not days. So once you've overdone it, and the patient only knows they've overdone it in retrospect, you've overdone it.
Yeah.
And then we're all staring at it, wanting it to heal. So if they let it heal first, then they have a much easier ride, and they turn around and tell their mates and say, oh, well, actually, it wasn't too bad. I'm fine.
Yeah.
And you also get lots of stories of people, all over the world who've kind of slightly had an average journey through all of this.
Yep.
And they're in trouble months down the line. So this is all about good advice and cushioning people through it. The other thing is patients often come and see me and say, well, do you know what? My physiotherapist looks after this professional team or that professional team. And you and I know with my soft tissue interest as well as my degenerate knee interest, they're two different skill sets.
Yeah.
So somebody who looks after an elite sportsman with a perfect joint, working on muscle strength to give them an advantage in elite sport, may not have seen a knee replacement before. Yeah. And therefore, you really need
quite a different approach and process.
A different approach and process.
Rehab.
Yeah.
Yep.
And so you've got to get the expertise.
Yeah.
And I can't tell you how important teamwork is, end-to-end care of the patient. The patient will appreciate that care.
Yeah. Sam, patients often come in and sort of ask, what can I do to just prevent that operation? Is there anything I can do? Or to just, they may not have a particularly grotty knee or a particularly degenerative knee at the moment, but they're often asking, what can I do to stave off that total knee replacement down the line? Is there any sort of advice that you might give someone to try and preserve those joint surfaces or try and keep strong? Is there anything that you like as an exercise or you think is beneficial for them?
Well, I mean, in a young person, of course you want to keep healthy.
Yeah.
You want to keep the weight off. excess weight, I don't think helps joints, and I think joints degenerate.
Increases force.
Increases force, and actually joint reaction force.
Yeah.
When I see very big people, it is very often that they've got worn-out kneecaps and other things. So I think remaining healthy is good. Understanding your anatomy is important. So if you've lost your shock absorber in your knee, i.e. your meniscus, then if you become an ultramarathon runner, it may be that without the shock absorber, you're going to wear it out faster.
Yeah.
The evidence is mixed. We don't have very good evidence. So you've got to choose your sport and you've got to be sensible about it, because often what a patient doesn't know is that once you've worn something out, you've worn something out. You can prevent.
And often it's too late.
It's often too late.
When they recognize that.
Exactly. So remain healthy, maintain the range of motion, and maintain ligament incompetence. Don't come with lax ligaments, because your reconstructive options become more complicated. Nutrition is important, and good balanced diets and things like that are undoubtedly going to help.
Do you think that, is there a place for people losing substantial weight first if they are obese before you go and replace their knee? The new GLP-1 agonists are transforming weight loss. They come with some pros and cons, but people can drop weight fairly rapidly that have struggled. So is that going to benefit them to drop that weight before they have a total knee replacement?
I mean, it's hugely helpful, I think. I mean, the every little bit helps. Now, the GLP-1 agonists, I think, look really exciting. I mean, I think the human race is going to live a long time. And every now and then the human race discovers a class of drug that is going to transform human health around the globe. And I think the GLP-1 agonist probably falls into that category.
Completely. It feels that way.
It feels that way. And I think people are going to therefore get less diabetes and obesity.
Except some sarcopenia, some osteopenia
Absolutely. So exercise and I think muscle mass management may need to go hand in hand with that. Yeah,
which perhaps it's not at the moment.
It's not at the moment because people are excited about the advent of the drug, but actually there are other things. I go back to everything in life as every action has an equal and opposite reaction.
Yes.
Occasionally, I see very big people, and there not only might you need drugs, but you might need weight loss surgery.
Yeah.
Because actually, if you're very big, you have other comorbidities, which actually makes the whole thing. That's right. So that can be very, very troublesome.
Yeah. Okay.
And therefore, if you go off and lose 20, 30, 40 kilos, and you're 150 kilo human, suddenly it de-risks the operation.
Yeah.
But if you are 78 kilos and you go down to 76, it might not actually make that much of a difference.
Yeah.
So these things are fairly nuanced, I think.
Yeah. Okay. Sam, I think that's been super enlightening and incredibly interesting to get your insight and expertise on this area, because you, frankly, have seen a lot of this and done a lot of this. So I'm hoping that our audience has found this incredibly useful, because I've learnt a lot, and I thank you for your time.
Simon, it's a great honour being here with you, and if it's helpful to people, then it's going to be useful. So very nice to spend the evening with you.
Perfect. Thank you, Sam.